we are ready, and we are preparing for this conference. Lot of insight that we are going to get and gain, and then go back to our workplaces and implement the same. So before we talk about the conference in details, we will discuss and some important topics during these pre-conference webinars. So, very important topic for this webinar is enabling patients for patient safety. As a healthcare professional, we all drive this day in, day out. But we understand we really need to know that patient safety is becoming a cause of concern in the healthcare, because healthcare delivery system is becoming very specialized and complex in day-to-day routine. In fact, patient safety is a concern focus across the world. So we really need to understand what all things we can do, what all best practices we can implement. Uh, not only the responsibility of the healthcare professional. It's about how we can, as a healthcare delivery system, we can coordinate between the teams. How can we work with our patients, caregivers, and also how we can enable our patients to create a safe environment, not only for the patients, even for the caregivers, even for the healthcare professionals. So working towards this, it's a day-to-day job. It's a never-ending goal which we have in front of us, and we need to keep driving this day in, day out. Uh, for enabling this, for helping us, we have I would say, an organization who supports Patients for Patient Safety initiative, and they call this as a movement. It is a movement for sensitizing and empowering the patients and the caregivers. See, it is very important for all of us to work together to create a safe environment, not only in the hospitals, not at the workplaces, but at home also, where the patient is there. How we can empower and enable our caregivers to take care of patients in a well manner, so that we can avoid the harms which gets created despite having so many processes, policies in place. So trust me, this is going to be a very informative sessions, and we have two of the very renowned esteemed speakers with us. Uh, as you all know, we have two speakers with us, Miss Nadira Chaturvedi. I will just give a brief about Ms. Nadira Chaturvedi. She serves as the co-chair for Patients for Patient Safety Foundation, which is one of the most renowned organizations supporting us in driving patient safety. As a management consultant, accommodation social entrepreneur, she holds an MBA from IIM Ahmedabad and boasts over around 40 years of work experience in the corporate sector. Additionally, ma'am has, in the last 15 years, she has been serving as a professor in business studies, imparting knowledge to the postgraduate MBA students. She also demonstrates commitment to social development. She's actively contributing to projects focusing on health and education of underprivileged and marginalized sector of the society for 17 years. We have Ms. Nadira Chaturvedi with us. And also have Mr. Som Mittal, who's a very renowned name. It's an honor for me to introduce him. Mr. Som Mittal is the chair of Patients for Patient Safety Foundation in India. He is the former chairman of and the president of NASCOM. Currently, he holds the position on the boards of several corporations, social and educational institutes. With a background in senior leadership roles at HP Compact Digital Equipment and serving as Wipro's chief executive, he brings extensive experience on the table. Additionally, he acts as an advisor to both the corporations as well as to the government. Mr. Mittal has been recognized for his significant contributions, receiving several prestigious global and national awards. So we will start our webinar with a lot of insights from Mr. Mittal first. We'll hear it directly from him, how he's driving it and why it is important for us to focus completely on patient safety. So I open this session for Mr. Mittal to take this forward. However, I would request the audience to please keep sending your questions to us, which we will take at the end of the session. We will have a question and answer round. So please, if you have any doubt, do let us know. Please send in your questions. I open this forum to Mr. Som Mittal. Sir, over to you.
Thank you, Harkiran. Thank you for that introduction. And thanks for inviting both of us for this session. And I'm sure your conference, as always, will be a big hit. As you mentioned, patient safety is extremely critical. And I must compliment the medical fraternity for the amazing work that they're doing. I think all the work that is happening on patient safety and managing diseases is evidenced by the fact of the increased longevity that we have seen over the last few decades. Even in a country like India, we've seen now, increased longevity. The complex procedures that you do, the innovations that are happening in hospitals, I think has led to lifespan being increased. I think while the lifespan is increasing, it's imperative that we also increase the health span. I think during that long life, we'd like to see people healthier during the entire period. In spite of best efforts by medical fraternity, the errors happen and they will happen. And the question is, what can patients do? While there's a lot of work that the hospitals and healthcare providers are doing to reduce harm, I think patients can play a big role, and I think that's exactly what we want to do. So as we go forward, just want to explain to you who we are, why we are doing what we're doing. Varsha, can you put up, please? So disclaimer, and I think your introduction said that we are both not doctors, but at the same time, like most of us who are on this conference, in fact, everyone, we have either been patients, are patients, or caregivers. And if that is the case, then we all need to play our own role. Both Nader and I, who are also classmates, we have both had avoidable harm, and we have seen that happening in our own family, and I think around with our friends. So that's what motivated us to take this initiative forward. Basically, CAHO, which is an organization which focuses on quality and patient safety, encouraged us to take the patients and bring them into the centerpiece, because they were anyway doing what they will with the healthcare organizations. So our foundation is a not-for-profit trust. Our only aim is to help reduce medical harm that happens before, during, and after the treatment with active engagement of patients and caregivers. So the only thing we're doing is get patients to have active engagement. We are sponsored by CAHO. We are working with 400 hospitals plus diagnostic centers across the country. Large number of senior physicians are working with us. And as a patient-centric organization, we are leveraging all the work that great organizations are doing, like WHO, healthcare providers themselves, and a lot of research that's available. But all we are doing it is making it relevant in the Indian context and making it relevant in language which is simple for patients. So that's what exactly we do. Now, if we go down to why this work is so critical, next, please. You would see that. Can you move the slide, Varsha? All the research that's been done by WHO is showing some statistics which is very alarming. 1 in 10 patients globally suffer harm during hospitalization. Medication errors constitute 50% of avoidable harm. If we look at OPD, 4 out of 10 patients are harmed either due to missed or incorrect diagnosis, medication, prescription, or communication errors. Unsafe surgical practices or problems that happen and complications that come into during surgery, it happens in 25% of the patients. Calibration of equipments, and hence the data doesn't come out right. But as you would notice on the right left-hand corner, bottom corner, patients also create a lot of this harm themselves, right? Because of their ignorance and non-involvement. And up to 50% of this harm could be avoided if we join hands together with the healthcare providers and made it happen. The question then would come, is this alarming? Is this data valid only in certain countries? Actually, you'll find that similar errors and similar magnitude is happening even in developed countries like the Americas or with the NHS in UK. So if there is so much focus, why do those errors happen? And I think it's important to go to the root cause to then say, how can we prevent it? So if you look at the next piece, these errors that happen are from the healthcare providers' end. There are so many interventions that are happening all the time. There is judgment used at every stage. No two patients are the same, and hence, is to human. These errors will happen in judgment. They will happen in diagnosis. There are also, particularly in the Indian context, too many patients. A large number of patients are there, and the time that the doctor has is limited. The staff is overworked. We are sometimes understaffed. We don't have enough nurses. The communication between the patients, and the doctor and the nurses is inadequate, and there are errors that happen, and lesser engagement with patients themselves. But on the other hand, if you look at the right-hand side, patients do cause errors because of lack of awareness and engagement. A lot of us just ignore symptoms that we get. We think it'll get better. We don't even know what is emergency if it's happening. And we miss the golden hours in a lot of ways. We are confused about the disease and the treatment. And, when we sometimes are asked to take tests, we probably ignore it, saying, why do I need that test, etc. So I think we do not follow the prescriptions that are given. We don't ask the right questions. And even if we have doubts, we don't ask them because we are not prepared. And of course, in the Indian context, we also have issues of language and cultural barriers, which make the communication very difficult. So if you can see, if these are the causes for the medical errors to happen, then it's only that we can work together and solve this. So what are we aiming to do? Actually, next please. So we are actually engaging with patients and caregivers. And by the way, the patient word is wrong here. It also is not only patients who are there today, but people will become patients. All of us at some stage or the other will fall sick. So many people say, hey, I'm not a patient. Why should I read what you're saying? But the question is, you can't be reading this when you have an emergency. You need to know it now when the emergency hasn't hit it. Young people ask us, I'm young, why should I be engaged? But then you are a caregiver to your parents, and hence you have to be engaged. And you must know how to take care of your parents and what errors can happen. Many of us do not know what our rights are, roles are, and responsibilities are. So one of the first tasks that we are doing is to ensure that in simple language, because patients and caregivers understand their rights, roles, and responsibilities. And by the way, all that we talked about, rights and responsibilities, have been welcomed by the healthcare providers. In fact, they are using our material and putting up in their OPD and others to be communicating this with the patients. We are trying to communicate the risk and the causes of medical harm and guidelines to prevent them. We are guiding them on the roles that they can play, also providing them alerts, tips, and advice for a safe patient journey. And I think this point of safe patient journey is very important, because at every stage, I think harm happens, as Nadra will indicate to you. And we said it's not only going to be, so you get well, you come back to the home, you have recovered, but knowledge of healthy lifestyle choices before and after illness becomes even more. So what we're doing should not be confused with wellness. It's about avoiding harm. And Nazra, maybe you should take on saying, how are we doing it and where do you think harm happens? You're muted.
Thank you, Som, for setting the stage so well. And I think the audience is, a lot of y'all are medical people. You understand that, yes, y'all are doing your best. And yet there is harm. And that was the question that was teasing us when we began this journey about 2 years ago. Som and I got into it, as he said, because we had personal experiences of harm. And I will add, I had also experiences of good things that happened. So it's not just harm. But sharing or extending what he's already said, harm happens and we were confused. Why does it happen? We sorted that out. But where does it happen? Who's responsible? And only when you know, coming from a management background, if you know the problem, you can overcome that problem. So we did not go the anatomy route. We did not go the physiology route. We just went from the mind of a person who's actually about to fall sick or has already fallen sick. So we picked up a simple method, a simple track, and this became our GPS along the way, that when we have symptoms, do we know they're serious or we don't know and we ignore it? I mean, to give an example, a very close person in my own family, 2 years, dental problems, 2 years, mouth pain, mouth burning, dental implants, remove, etc. But nobody, including the family or the dentist, thought of checking for something bigger. And when the final diagnosis came of an advanced cancer, obviously the prognosis was bad. So weren't we both responsible? I think we were. Similarly, I mean, I met another person and he did not want to do chemotherapy. Okay, just don't do chemotherapy. He just wanted surgery for his cancer. When we explained the fallout of not doing the chemotherapy, of a possible recurrence, when he was enabled with the knowledge, he decided to go in for the right treatment and the right options. This happens throughout, whether it is diagnosis. I know people who hide their symptoms because they're afraid, they're shy, they're ashamed that somebody, particularly in mental health spaces or particularly in private parts, they don't talk about it. A result, doctor doesn't know, the nurse doesn't know, and the person gets sicker and sicker. So unsatisfactory protocols, unsatisfactory compliances, we come back home even after the best of treatment, but we felt fever is gone, why should I take my medicine? And then we get back a cold, a cough, and we blame the doctor. So along the way, I think a lot of harm is happening. And this is happening because we have doubts, which we don't clarify. We're afraid of asking the doctors, which he didn't mention. We're afraid of a backlash. We are not sure, they might just prescribe some more tests. And then all these things prevent us from actually doing the right diagnosis or doing the right work that we should do it. Preventive choices are at the last. So if I want to summarize this statement, next slide, Sarasha, I was wondering, and we were wondering, what is the missing piece? You know, we went to these conferences just to learn what the doctors are doing, and we picked up what Soma has already mentioned, the tremendous amount of work, research, artificial intelligence, robotics, genetics, so many new concepts are coming in, continuously being practiced. There are quality professionals right here, but still the harm is happening. So there was one piece missing. When we wore our first hat, and that was wrong of us, we quickly learned that. We thought we'll go and tell the doctors what to do and the nurses what to do. We actually came back with the tail between our legs, and we said, no, the missing piece is actually the patient. Now, this chart that you see is an inverse picture of the ideal patient. And we picked this up. We picked up our knowledge of the patient journey. We picked up our knowledge of an ideal patient from two sources. Number one, because we are normal people, because we have social circles, because we interact with people, we just kept asking, thinking, listening, and building up stories along the way, experiences. When we talk to the healthcare people, they themselves had issues with patients. And this, therefore, a chart of an ideal caregiver or an ideal patient, as we've already spoken about. So therefore, I'm going to summarize this. And we said two things. Number one, the circle of influence has to be not just the patient, but the caregiver, not just an ill person, but also a healthy person. Hence, what we are doing is giving awareness to many segments, age-wise, demographic-wise, socioeconomic-wise, career, urban literate, all the people. What is the line that we're giving? The spectrum of issues has already been shown in the other one, earlier one. We're showing them across before they fall ill, during the treatment, and when they come back home. So this is what we are doing. This is to whom we are doing it. How are we doing it? Next slide, Rasha. We've already explained. Now, we've explained, Som has explained that we are trying to gather, to aggregate best practices, which we do. We are not a prescriptive person. This is not a forum for claims or for blames. It is purely learning, and purely learning with one key element, which is different, which is inside out. We are going to learn what we as patients are going to do. I'm going to simplify that further. When we go to the doctor, when we go to a hospital, the doctor says, your health, my responsibility. And the doctors and nurses are all dedicated. They're overburdened, but they're dedicated. But what do we do? We surrender, we don't ask, we don't interfere, we don't learn. So if we just tweaked one word, and that gave us the clue for all the work that we are doing, a simple tweak. It's hidden somewhere in this letter, I suppose. We said, instead of saying my health, your responsibility, we say my health, my responsibility. That simple word changed the entire focus, entire orientation of our journey, and the how became so clear to us. How do I approach a doctor? This poster was a result of a direct interaction with 30 daycare cancer patients whom I was talking to about 2 months ago. And I said, show me your reports. Everybody took out their bags full of reports. They had lists, they had bills, they had teacups, they had residential things, they had all kinds of things. But none of them, except one girl, she was 21 years old, had them in order, in chronology. She was the only one who had her questions and her doubts in place, and she was smiling. The rest were hassled. And I said, I was going to talk to them about their rights of asking a doctor or meeting a doctor. Far, far from the rights. What was their role? If they had only kept it in chronological order, if they had kept all their cards together, if they knew their symptoms, if they had written it down, and I'm not talking of here, even normal people, even literate people, they do that. We are running from a meeting, rushing for a lab appointment, rushing for a doctor's appointment. We go there, hassled. We talk to the doctor, we come out. Oh, doctor, I forgot this question. I go back in. The doctor will listen once, maybe twice. Third time he says he's already got a next patient. So if we had prepared before we do it, before we meet, maybe all our doubts would be cleared, our symptoms would be clear, the doctor's time would be saved. So we are doing this as a work that a patient has to do, a caregiver can do, and a doctor's time is saved. So, and this, by the way, is being put up next to OPD windows in hospitals, in clinics, and it's become a simple but a good technique. Next one. So this is the kind of work we are doing, which is oriented to what I can do to care for myself. 2 goals, as already mentioned, preventing harm and promoting safety. Not necessarily the same, but yes, aligned to the same. And I think doctors and nurses are also doing the same thing. So while we come from different routes, our convergence will be the same point of building a healthy society. So I mentioned about wellness and health. We are talking to lots of corporate people, students, institutions, NGOs, all kinds of forums, and there's lots to do here. But everybody says the doctor is wrong, or the nurse is wrong, or the hospital has to do it. What about me? And we say no. If we came into the picture and we did something, then we would help ourselves, and God helps those who help themselves. As simple as that. So even diagnostic errors, we are the ones who are responsible. We hesitate, we don't show, we don't disclose. So these kind of pictures are helping, and we've got them in all languages. Next, we've got them in vernacular, we've got them in text format. Varsha, next one. Yeah. And now look at this one. So many times, an emergency. I mean, you have an emergency, you don't know where to go, you don't know which is the next hospital, you don't know, I don't even know the meaning of accreditation. I mean, that's a big word for me. I see a certificate of NABH at the forefront. I don't know the validity. I don't know who audited. So, but if I knew beforehand, now and not in the future, the title of this symposium, I think, is Future. But I think we need to begin now. If I know, if I do my homework, if I have reliable information before I need it, maybe I won't use it at that time. Maybe I'll use it later. But I can take the right action. I know where to go. I know who to call. And that golden hour maybe is the first aid that I can do. And we're coming up with a series of first aid, with a series of golden hour questions that can help save a life and that can help the doctor get better results. So our work is focused on, oriented about what we can contribute. And it is aimed at the entire conundrum, the entire continuum of care before, during, or after. And that's why I think, even if you're traveling, next one, even if you're at home, even if you haven't taken a preventive health checkup, all these things, I think, are helping us. One common question that comes up, why should I listen to you? Why can't I just Google? Can you imagine? You have an emergency. somebody's having heart palpitations, somebody's perspiring, somebody's having a seizure. Do you have time to go to Google? Nothing wrong with Google, but it'll throw you 10,000 search results. How do you know which is right? I think we are doing an aggregation, simplification, a text, bulleted points to actionable points, and keeping it visual as well as audios. We'll come to that at the later end. But this is how, this is for whom, and this is what we are doing. So I'll leave the rest to it. It'll come up more. There are many more strategies coming up. So don't go away. But this was just a window into what we are doing. There's lots more on our website available. Thank you. I'll give it back to Karan.
Thank you so much, ma'am. So you've given really nice insights. In fact, I am learning a lot of things from this session, how to go back and take care of my parents. And then when I become a caregiver, what are my real roles and responsibilities here? So it's a great session, learn a lot of things to learn. So I think we roll back again to Som sir and understand from him how and what hospitals should do to actually engage patients. This is very important because engagement of patients revolves around this entire topic. So Som sir, your insights on this, please.
Thank you, Karan. Thank you, Nagra, for presenting this. And, as just to take on from what you were saying, if you are having symptoms of stroke, right, and you don't know it, right, you actually said, let me rest here and, it'll get better. You're losing every second, every minute. So and by the time, you might not have help around you, right? So it's not only for caregivers, it's for you to know your own symptoms and what do you do when it happens. We have had cases where people landed up at the wrong hospital. They went to the nearest hospital because you went to the hospital, but they were not equipped to handle a stroke. They were not equipped to handle a hemorrhage or a heart attack. And, we all live here. I'm wondering how many people know which is the hospital they should go to because they've never been to a hospital. Is it fully equipped to handle this? Do you have the number available? Should you wait for the ambulance to come and get stuck in traffic? Or is the kind of ailment where you can actually put the patient in the car and rush? Because if you lost the golden moment, it's gone. The last slide that Nagra had put up was on travel. All of us travel, right? And many of us are on permanent medication. And our bags get lost at Heathrow Airport or somewhere, and we land up at the other place without a prescription, without enough medicines. And even we only know the brand names of the medicines. Now you are lost in a new city that you went to. So these are common, careful issues that we are raising and helping out. Clearly, the topic, Karan, was a future glimpse. And actually, this, for us, as you mentioned, it is perpetual. I think this issue of engaging with patients is the future, right? Of course, AI tools will help reduce, diagnostic errors. They'll give better judgment and decision-making capabilities to doctors, but patients would always continue to play a role. And I think this collaboration is, most important. The focus, in my opinion, as we proceed further, is not going to be only about managing disease, but also managing the patient, their emotions, the empathy that they need, the hand-holding they need. So I think a lot will become patient-centric. Not that hospitals are not, but, mind you, there are large hospitals, small size, medium size, 80% of the hospitals. In fact, we were doing this analysis, and I think it's a very, very small percentage of hospitals and clinics that are accredited. So they don't even have the basic processes. And you don't have a choice necessarily in your city to go to an accredited hospital. I'm sure you will get there, but you can play the other side role as a patient. Now, from the hospital side, the question is, patients come, we engage with them, we treat them. What else can we do? And I think this cycle is very important to know that the healthcare providers have a lot to gain from this. Early detection and prevention, right? So preventive healthcare. We have seen so many people who say, I'm healthy, I'm 40, why should I get a checkup done? And then you have found that majority of the non-communicable diseases, diabetes, hypertension, you just name them, they come undetected. And by the time you detect them, it's too late. So early detection and prevention and educating people on this is important. And this will lead to reduced medical errors. There will be better outcomes. I think we all need to work to improve the trust between the healthcare providers and patients, because that trust is extremely important. And I think when you engage with patients, you build a trust, because the doctor or somebody in the hospital is explaining to you, why do you need this test? Why did we select X test and not the Y? And I think that engagement itself will help improve trust. Doctors, they take this oath, which is a very critical oath that they're going to be serving. And just imagine the personal and professional fulfillment that they get because they were able to detect early and get much better outcomes. Of course, it leads to loyal customers. People don't come to hospitals by choice, right? They haven't budgeted that expense. They are distressed. But if you treat them well, you take them through the experience, right? I think the loyalty will increase, and that leads to the reputation of the hospital going up, and of course, profitably. And with the increasing expenses and more sophisticated equipments coming in, how do you afford that in a hospital? And I think that can only happen when you have loyal customers and dissatisfaction. So there is a very good reason to create this win-win situation. Patients will gain anyway, but I think healthcare providers have also to gain. So what strategies can be adopted by healthcare providers to engage with patients? As I had mentioned, that we are all patients. Sometimes you think in your mind that, why does a hospital exist? It actually exists because of a patient. The only revenue stream is a patient. So in a sense, patient is a customer. And as I mentioned, he's a very distant customer than a customer going and buying something in a shop because you go by choice. But here you're going in not by choice, but so the expectation is not to be treating with what will be customer satisfaction, but patient satisfaction is very different. The only expectation they have is a quick and safe recovery, and that somebody has heard them out empathetically. So getting patients centricity across the organization. Now, this is a very simple word, but if you look at the patient's journey from the time a person enters the hospital, there are so many moments of truth. It's a large hospital. How do they find a place to the right doctor? How long is the waiting time? How was the billing procedure? What happened when they got admitted? What happened in discharge? And of course, the clinical outcomes itself. So we have to involve the entire people. It can't be just the PRO. So this is not patient engagement through a PRO. It's far, far beyond. It's how the nurses deal with you, the paramedics, the doctors, and everybody else. So we have a very good saying, Harkaran, that there should be in any organization only two kinds of people. And if I had to put it for a hospital situation, we have only two kinds of people in a hospital. One who's directly treating a patient, and the second, somebody who is serving somebody who's directly dealing with it, so that everyone can see their role and how they can help the healthcare providers in becoming patient-centric. Not working in silos, putting patient in the center of it all. If we really mean it, and I think that's the future, I think we must give a seat on the table to the patient, right? Not by doing surveys and then having net promoter score. Yes, we need all of that, but give them a seat on the table. Just like we have customer advisory board, these patients will help build partnership. You will get real good inputs. This is not like Nadra mentioned, a complaint forum, a medical legal forum, none of that. But you'll be surprised how much benefit the healthcare providers can get by creating this patient. Then, patient-centric education and awareness programs. How do you involve them in shared decision-making, informed decision-making? We all sign consent form. I wonder if we have ever seen, it's no different from my clicking on any app saying I agree, or whenever an app comes out and it says, should I use cookies? And we say, yes, I agree. It's just like their way, but a consent form is informed decision-making. I must know the risks. I must know what will happen, right? And sometimes the patient is not in a position, but we can tell the caregiver. Most of the time, we don't have a choice, but I think explaining the whole purpose is not to have a indemnification, but more importantly, the patient should know. Of course, establishing a feedback and experience sharing platform, learning from your customers. This is again not a feedback of the kind saying very satisfied to not. I think we miss out on the nuances, small things, because already you're doing it. But if you put the patient there, they know where it pinches, what didn't work for them, etc. I know that all of you are trying very, very hard to reduce the time for patient discharge, but just imagine how elated a person was when the doctor mentioned the previous night, "Ki aapko kal jaane denge, we'll let you go tomorrow." But then it's next evening by the time the patient actually leaves. So all the good work we didn't happen. I think the total experience there, learning from the customers would help. And I think it's a two-way communication that will be there. This to me is the future, right? Because we have seen how India has adopted technology, latest thing, and organizations like Apollo, you do the most complex surgeries anywhere in the world and effectively. So I think that will happen. So we are here not to tell you what will happen clinically, but just that little attention to getting patient centricity, I think, would be there. And then we said, we had a lot of questions. This is not a corporate. What is this advisory council that is there? And, CAHO actually has taken this up, is leading this effort. They've actually made a manual on how to set up patient advisory council. And we are partnering with them to provide the patient perspective. And Nadra, would you like to share, what can these councils do and how both patients as well as healthcare providers will benefit?
Thank you, so. Thank you. Varsha, stay on this slide. Stay on this slide. Go back, please. Go back to slide 13. 13. Number 13. Up to 13. Go back to Som's slide. Yes, this one. Yes, stay on this one. I'm going to just spend another minute or two here. When we talked about this whole seminar is about engaging patients and engaging patients for safe health. Now, when you engage patients, the previous discussion we had, I showed you some patient education material. That was number 3, which we are using to get people, normal people, non-medical people, to come on board, to come out and to proactively help the healthcare system to help themselves by giving them good awareness, simple tips, and actionable points. We also wanted to do one more thing, which I missed out saying earlier, capturing patient experiences. Because we tried a whole series. We have not yet succeeded, I must admit, but we are not giving it up. We call it Speak Up. When we mean speak up, it's not again complaining, but it's about sharing what you did or sharing a good thing or a bad thing. And when you share something good, I want to share something good here. I'll just give a quick example. It was my second day of my 6th chemotherapy several years ago, 15 years ago, in this very hospital. And it was about 11 o'clock, and I had settled down after my protein sandwich, paneer, which I dislike, but I had to eat it. I rested because I knew in the next 3 hours, the IV is going to do its job, and whatever the toxins are going to get inside my body and kill my chemo cells, etc. Now, as happened, within 5 minutes, I started perspiring. I became red, flushed. I was cold, perspiring as well as cold, hot as well as cold, and I lost consciousness. Fortunately, my daughter was in the room. More fortunately, she observed the signs. She didn't know what was happening. She immediately called for the nurse. She called for the doctor. 101 doctors in that hospital. Everybody was attending a conference. So there was no doctor available. My daughter didn't know what to do, but she knew what signs to watch out for. In comes a nurse, an experienced, I call her an angel who saved my life. And that's why I'm sitting here and talking. Immediately, she discontinued the IV. She removed all the cannulas. She removed all those pipes. And she gave me some injection, which revived me. I didn't know anything about this. I got to know much later. Now, what really had happened? That nurse had informed my daughter what to look out for. She had taught my daughter the symptoms to watch out for. It's not goody, goody, goody. It's not, as Som said, everything is good. People come around, the PR people come, all good. And we say, yes, all good. Nobody asks, how is it? Just a simple tweaking of that question. How are you? Nobody asks. They say, all good. So you want a rhetorical question. Because that nurse had taught my daughter and my daughter was alert, she informed the patient. So the caregiver was informed. The experienced nurse took the protocols. She was informed, and a patient, namely me, was saved. So there are some good things that we do. And I want to share this experience. And there are many such wonderful experiences. I want to share the good ones and not so good ones so that we learn, so that we repeat, we appreciate those nurses. Things like giving a discharge summary. When you go back at the discharge time, you're hassled, the billing has taken forever, the patient is cranky, you're hungry, your children are waiting at home, you need to go back and cook, you need to resettle a long patient. So many worries. Nobody tells you, you don't read, you don't ask what medicines to take, what to look out for, whom to contact. There's a printed number, which never, by the way, never works in any hospital. I'm sorry to say that. There is no person from the doctor's team who's willing to give a mobile number, and the patient rushes back and we don't know what to do. Here comes a good experience. A nurse packed up 5 days of medicine in small pouches, 3 times a day. She made bundles of lal goli, pili goli. That's the way we used to get medicines when we were young, a pink dawai and a black dawai or a white dawai. And those 5 pouches for 5 days helped the patient go back home, settle down comfortably without missing a dose, and recover sufficiently to take care of our own medicines. So there are these lovely experiences which we wanted to conquer. We did not get them. We asked for incident reports. We did not get them. So Som and I was struggling that there is so much to be done, so much to be learned. And where do we find it? That's where we got magically something dropped in our lap. Next slide. We got a tool, a vehicle, next slide, Varsha, which is called the Patient Advisory Councils. In one stroke, we could kill 3 birds, maybe 4, right? This is a tool. See, there is a strategic intent, but nothing works only in intent. You need a vehicle, you need a structure, you need a process, you need a monitoring that process. And this particular thing called Patient Advisory or Patient and Family Advisory Council, as it's called in some countries, was a new concept. Internationally, yes, some countries have it, but India, we were the first. Kaho is the first, and we also have a manual. And this council is very simple. It is a composition, it's a partnership of 3 or 4 patients, 3 or 4 doctors that come together, mandated to work together. They pick up some problems and they'll work together on solving recurring or chronic issues. They will listen to the experiences and the feedback, actually listen from the patients. And the patients in turn have a forum to express themselves. When I listen to you, you listen back. When I talk to you, you talk to me back, right? So listening is a very important part. And therefore, the last part, effective education of patient community, actually comes in naturally flowing from this Patient Advisory Council. So it builds back a partnership in a structured manner. It builds back, it gives you a forum for communication. It gives a forum for working together for common goals. Next slide. So this is the beauty and the advantages to both. As already mentioned, the hospitals benefit because they can show, they can display, they can demonstrate their intent of looking after patients, which is already there. They can demonstrate a proper feedback and communication forum. They can in turn actually learn the weak spots, that everybody has weak spots, every management, every organization has it. So when you zero down on that, when you narrow down, your efforts are saved, your stresses are reduced, and your satisfaction and your resources. In fact, even attrition, I'm sure, would be less, and retention of your secondary staff, nurses, etc., would be better because the tensions are come down. And even we have not written it in this slide, but I am certain that the expertise that is there below the doctor, in his teams, the resident doctor or the nurses, which are afraid to open their mouth, they will also start telling you what can be done better. And when we listen to the grassroots solutions, I think every organization benefits because they are the doers, they are the carers. So the benefits are going to be far more than you can even see on one slide. So what about the patients? Is it beneficial to the patients? Do they benefit? Why should they come and share it with you? Next slide. Yes, of course. We are all in it together. The difference is my health, my responsibility. I'm no longer a recipient. I'm a partner in my own decision making. And when I take decisions, I abide by them. There is no dissonance, or at least lesser dissonance. I listen, I comply, and therefore I come back with a safer, sounder experience of working, whether it's a preventive health checkup, whether it is a lifestyle change, or whether it's just keeping medicines safe at home. So many benefits to all of us. And we must expand this definition again and again. It's not only patients, it is actually potential or dormant patients, it's young people, it's older people, it's all of us together. I would like to add one more here for the patient, for the PACS and what hospitals should do. Som had already mentioned, and we've seen that, and I think there's one question even in the chat box. Large tertiary hospitals are overburdened. They're fraction, I think there are 2% of the entire 60,000 healthcare facilities in India. Next slide. But there is, and 90% of care is done at home. 10% is done in hospital. Those are the figures. I'm just setting it out. Is it possible for all of you all, just 2% to take care of the rest? No. But through the PAC, if you take responsibility for your area, for your region, maybe you can become the catalyst, the change agent, and enable the primary PHCs or the CHCs or the district hospitals to perform and work better. And the PAC would be a forum where you can have these things. So would you like me to explain about the steps? I'll just simplify this. Okay, I'll just add a few lines about how do you form a PAC? What are the simple steps? CAHO has a manual, but I'll just simplify this. I've already mentioned it. The intention, the goals should come from the leadership. The resources, manual as well as financial, as well as space should be dedicated. There should be a dedicated room, a dedicated facilitator or a secretary, and you have to choose people to man this committee, both from the hospitals as well as the patient reps. You can decide their roles, spell it out so that there is no freebies being asked, there is no blame being done, and the do's are as important as what not to do. So the orientation of both would be very important. They then meet periodically and pick up from a host of problems the most important or the most chronic items. It could be discharge delays, it could be hospital-acquired infections, it could be front office not understanding, or it could be don't know where to go from OPD to OPD, or it could be long waiting lines before somebody gets an appointment. Anything. And patient experiences, incidentally, we are not entering the clinical domains as yet. We are still on the patient experiences or the contributory factors that would help clinical outcomes, but we are no way professing to be prescriptive in any of this. So please do not misunderstand whatever we say. So the areas of improvement are then picked up by a cross-functional team and a cross-hierarchical team. They work, they solve problems, root cause analysis, fishbone, whatever. And then they find the successful solutions, reported back to two people. One, internally, that's where the hospitals benefit. Second, give it back to the public, to the patients that we improved on so and so things. This communication will help you to go into big places. So these are the 6 steps, and I'll give it back to Saul.
Yeah, no, I think, Kiran, we have just 10 minutes. We're so passionate about what we're doing, and we're passionate about the fact that healthcare providers are welcoming what we're doing with them. Happy to take questions if you have any, or from the audience.
So I open this forum to all. Please put in your questions in the chat box. We keep this up. However, we have got 2 questions, sir. One is very interesting, which comes from Shubham, and actually what we have seen is that patients are not open to go to doctors and ask questions. It's not easy for them, especially if we look at the healthcare at the rural areas, villages. They really don't understand what healthcare or what the entire healthcare system is. For them, doctor is they generally get intimidated by these doctors when they enter the room or when they go and meet the doctor. So how can we enable? How can we make them more engage them in this kind of a care program? It's very difficult, but we would like to hear from you, sir. Some insight if you can give us on this.
No, I think the problem is real. There are language barriers. There are cultural barriers to this. So not all the questions have to be answered face to face. In the OPD, for example, we are all sitting waiting for our turn to come, right? We have a lovely TV that is going on there, and that's keeping us entertained. But there itself, I think we can have common questions being answered. There are lots of education stuff that can be given. I'm sure if you categorize the issues that we have, there will be 6, 7 standard ones where you're giving actually a written, almost like when we have a discharge, there is a stuff that we are given about diet and so on. So there are, for many of these ailments, some standard stuff for them to read. I think just asking, them, making the environment comfortable, right? We know that the doctors are also as stressed as the patient is because they have so much to do. But, we've seen many doctors who make it easier. They make the environment easy for communication. Many cases, the nurse does that role because the doctor doesn't have time, right? There is somebody who can talk to them in their language. So I can tell you one thing. If we get to it, this will be solved, right? So once we know that this is the problem happening, it is not about cost. It's just about attention to that detail. Nada, you want to add to this?
Yes, I would add that giving a dedicated space, the intent is always there. The doctors have many times told us that we do not have the time to talk to every patient. We tell them, but they forget. So when we make a structure, these are some of the slides that are there in a hospital. This is a real picture which I got this morning, and I was delighted. I was wondering how we can prove that we are doing something good. And this is a very good hospital in Bangalore, and they have put up our posters for patient education, how to meet a doctor, how to keep your medicine safe. What are your roles? What is your duty? What is the responsibility? How can you help diagnosis? Now this, thanks Varsha, when this comes up, and on the TV screens, when this is kept in the hospitals, when this is spoken in their own language, we will also have videos and audio visuals for this. When it is imparted to them regularly, that will help. Number 2, a counseling section, a counseling room, maybe next, there are many prayer rooms I have seen in many large hospitals, where the patient is calm, where they're receptive, they will listen, and I think that teaching them would also help. Third, most important, while we are in the IP patients, and this was all about OPD, but in the IP sections, if the nurse took time to teach a caregiver how to clean a G bag or how to empty the catheter or how to give an injection, I think the patient will never forget, the caregiver will never forget, and then they will realize the value of learning from the patients, and it will help both the people. And one less irritating customer in the bed for all of them. Otherwise, they keep asking and pestering the nurses. So that's what I would say.
Thank you so much, ma'am. Lovely answer. And I think we need to practice this day in, day out. One insight which I would like to share with all of us, one is that I take care of the service excellence. So feedback is the bread and butter for me at Apollo. So we have actually deep dive into these feedbacks with what comes from the patient, and we have realized actually 43% of complaints we could have easily saved and would have not turned into a complaint if there is an effective communication process was implemented or practiced on ground. So I think communication becomes a very important aspect to drive patient safety, especially. So we could definitely need to do that. Also, we have one more question from Dr. Ramesh talking about how to any insights basically on the home healthcare scenario. So this was about hospital. Now there are a lot of programs which are running to improve healthcare at home, and home healthcare services are actually the market is picking up. So how do we drive that, sir? input from both of you, ma'am. And
yeah. So, I think there are home care, there are two aspects, right? One is not every home care involves needing specialized help like the ones that hospitals, and thank you for thinking through, because I think for patients to continue to convalesce and get better in the hospital is quite risky, both for them and for their caregivers, because hospitals in an area where there will be infections and so on. So they're much better off in their home environment, but they still need certain facilities. On the issues that we have seen on the home care is the last mile quality of the person, right? The processes are very good, but the person who delivers, there's a high attrition level. I think it's getting better, right? These doctors, the attendants are getting better, the nurses are getting better. But this concept has to be understood that you don't have to be in the hospital. And particularly as we look at geriatric care or patients that have long convalescence, they don't need to be coming to the hospital to do it. But there is this other aspect of how caregivers can take care of the patients at home, right? How can we prevent falls? How can we prevent infections? And that education is also as important. So one is about hospitals helping us do it, but even after they withdraw, there is still care to be taken, which I think we need to educate. And all of us are caregivers, right? We are caregivers to our children, we are caregivers to our spouses, we are caregivers to our parents, right? So we also need to invest and learn. So I think one of the things that the hospital should do is to create a manual for us, right? On specific ailments. I think that should work.
Can we add palliative care to that? Because palliative care, unfortunately, the impression is it's end of life care. It's not always end of life. It's symptom care, and symptoms are going to happen all the time. Also, I'll just add to Som, the preventive, the symptom care, watching out for symptoms, watching out for negative symptoms is going to be as much a part of home care. And we are coming out with a series of questions and guidelines for this as well very soon, taken from the best of the existing sources.
Thank you so much, ma'am. Thank you so much, sir. One personal question which I would like to get your insights upon. So you talked about the Patient Advisory Council, and we are also at Apollo very passionate in driving this concept. We really want to, we are working towards this. One thing which I want to understand, looking at Indian healthcare system, it's very difficult nowadays to actually convince patients and get them on an advisory board kind of a thing, and ask them to come frequently, meet us, and then help us in improving our system. So how do we actually get patients on board? This is a very difficult thing which we are facing right now. So would like to have your insights.
No, yes, I think anything that you start new sounds big and difficult, but you'll be surprised. You have all kinds of patients coming to a hospital, right? There are a lot of people who are from the corporate world, they're from business, they understand. So one of the things that you don't want is just a noisy patient just making noise. They're already representing the case. I think we need them to be representing the patient body, people who can, after the meeting, talk and collect information and come do some research. So if you are careful in selecting the people and have a representation, both men and women, they should be patients of your hospital rather than get them. There are enough people who can come and give you advice, but they should be your patients from your hospital, right? Because they're talking about your experiences in your facility. So if you just look at the profile of the people, get initially people, right, both genders, right, who have been through an issue. In fact, people give feedback. The person who wrote the most feedback, get him involved, because he took time he didn't just move away and change the hospital and then complained and spoke negative about the hospital, about the doctors and so on, but he cared to write about it. Get him in, right? Because he wanted to help. And I think those are the people that we shouldn't call him a noisy patient. We should actually say he's a person who really wants to help the system, right? I think you will make some mistakes like we do all the time, right? People from both the sides, but it'll get there. I'll just say, we have discussed between us at Patient for Patient Safety Foundation, we have started a journey which is never ending. We don't see an end. Similarly, all that we are doing from the healthcare provider side on patient centricity, patient focus is going to be a continuum, right? And we are only your partners in it. We are on the same side. We are taking your job and extending it to other patients in the language. When we put ourselves in the shoes of a patient, because we are patients, we understand what means to us and what doesn't, and we are collecting feedback from others. So I think this, we would request everyone to partner this, use our material, tell us what more we can give, correct if the material was not right, right? And help us in this journey for mutual advantage. I think this is a win-win. We have only one life. It's getting longer, but it should also get healthier. We don't want to be sick, but have a long life, right? And I think we can both work together and make it happen.
Absolutely, sir. Thank you so
Please
much.
do share your experiences. Please do that.
Definitely, ma'am. Definitely. So it's a never-ending journey, and we partner with you. We are there for our patients, and I think this was a great, insightful session. We have learned a lot of new things, despite sitting at the administrative side of the hospital, but learning a lot of things what needs to be done on ground. And Nadri, ma'am, thank you so much for sharing those best practices with us. Som sir, great insights from your side. Trust me, quite an overwhelming session for all of us. So I would like to really thank you, both the esteemed speakers, for their contribution and making these presentations for us, putting your insights, your thoughts to it. And I'm sure we are committed towards patient safety. And I pledged today, especially on behalf of all of you, that I will be taking care of each and every patient. We'll try to create a safe environment wherever it is possible. I'll do my best. So
Thank you.
thank
Thank
you.
you.
Thank you, Edgar. Thank you for that.
Thank you for your time.
Thank you, everybody, for listening to us.
Thank you, everyone. Thank you for joining in. See you at the conference. Thank you.
Forward.
Thank you, sir and madam. Thank you so much.
Thank you. Thank you, sir.